welcome to today's clinical question time case study. This time around, our cardiovascular case study revolves around angina. So let's get straight into this clinical case study. Mr. Angina comes in from the surgery and presents you with the following prescription. He tells you the sildenafil is new, but the rest of his angina medication he has had dispensed once before. Identify the 2 drug therapy problems present. Now, when screening the prescription, you'll be able to see that he's got a few prophylactic medications. So we've got an angiotensin II receptor blocker, got an antiplatelet, the aspirin, and we've got a statin, atorvastatin for his cholesterol. These medications are probably being given to help reduce his cardiovascular risk and the risk of a cardiovascular event. So the angiotensin II receptor blocker for the blood pressure, the antiplatelet and the statin all contribute to help reduce the risk of a cardiovascular event like an MI. Now he's taking a rate-limiting calcium channel blocker, which is the diltiazem, and that's probably there to help prevent future angina attacks. Got a nitrate, and that's Proronata PRN. That's probably there for symptomatic relief. And then we've got a Pde5 inhibitor, Phosphodiesterase 5 inhibitor, sildenafil, and that's probably there for ED, erectile dysfunction, probably as a complication of the disease itself, or it may have manifested due to a different cause. Now, the first thing that should pop out to you in these 2 prescriptions is that there's quite a severe interaction, and that's between this Pde5 inhibitor, sildenafil, and the nitrate spray. Now, there's actually a severe risk of hypotension and potentially circulatory collapse, depending on the severity in the reduction in blood pressure caused by this interaction. But you might be thinking, how? Well, let us go back to the mechanism of action of each of these drugs, and then from here we can help build on how this pharmacodynamic interaction occurs and put it more into context. So, how do nitrates work? Well, nitrates are prodrugs. So prodrugs being these medications that have to be metabolized into an active metabolite, and that's what causes the pharmacological effect and hence the biological response that's elicited. So nitrates are these prodrugs, and they become denitrated, i.e. they become reduced or they lose oxygen and act on this vascular smooth muscle. The vascular smooth muscle. In the end, that's where this drug acts, and they actually interact with intracellular thiol groups, or sulfaldehyde groups, so that's SH, the thiol groups. And from here, it's reduced to nitric oxide, or it actually becomes an intermediate S-nitrosyl-thiol, where it's further reduced to form this nitric oxide. Now, note there might be some minor action by an enzyme called glutathione S-transferase produced by the liver, but it has a very minor action if it is involved. Now, nitric oxide then activates a soluble smooth muscle enzyme known as guanylyl cyclase, abbreviated as GC. Now, this enzyme catalyzes the conversion of guanosine triphosphate, GTP, into cyclic guanosine monophosphate, cyclic GMP. And it's this cyclic GMP that's pivotal and causes all the effects that causes a reduction in blood pressure. Now, the first thing cyclic GMP does in order to cause, this relaxation of vascular smooth muscle we're going to talk about is it decreases calcium entry into the cell, and this causes relaxation of this vascular smooth muscle. And obviously if there's relaxation of vascular smooth muscle, it allows the blood vessel to actually gain a greater diameter, so the width of the blood vessel actually gets bigger. And what that means is you have a reduced pressure because you've had a reduction in peripheral vascular resistance, because that's dependent on, you know, the vessel diameter. Now, how does that reduce blood pressure? Well, remember, blood pressure is equal to cardiac output multiplied by peripheral vascular resistance. Now, obviously, you reduce that peripheral vascular resistance, you're going to obviously decrease blood pressure, in case you want to see it in a more written form. Now, this obviously can help in many conditions. So that's the first thing that causes that vasodilation effect. The thing you have to remember is that to go from this reduction in calcium entry to this, you know, relaxation in muscle, it involves the effect the reduction in calcium has on action potential. Now, we have to have a bit of a backdrop on action potentials and axons in order for us to gauge this properly and get a bit of a deeper understanding. So in case you're not sure on, you know, how an action potential works, I'll quickly recap it on the next slide. So say this is an action potential graph. There we go. So on the x-axis we're going to have time, and that won't be in milliseconds. And on the y-axis we're going to have voltage, and that's going to be in millivolts. So round about here we have what's called our resting potential, and that's about minus 70 millivolts. That's about minus 70 millivolts, and that's the resting potential. And the reason it's called resting potential is because it has the potential to change. So why is it you know, at a negative charge? It's because of protein known as the sodium potassium pump, also known as sodium potassium ATPase, because it's dependent on ATP to work. Now, this sodium potassium pump this pump exchanges ions, and it actually involves, as you can guess, sodium and potassium. Now, for every 3 sodium pumped out by this pump, it actually exchanges it for 2 potassium to go inside the cell, because potassium prefers to be inside the cell because it's intracellular. Now, as you can see, the net charge left over inside the cell is negative, because more positive is leaving the cell than is coming into the cell. That means it's net negative. So the inside of the cell, you know, stays more negative, and that's why we have, you know, a negative potential. So what happens is, say an action potential comes from, you know, further ahead the axon, and then it reaches here. Now this causes opening of some more you know, normal sodium channels to allow leakage of sodium into the cell, and eventually that tiny creep by those sodium channels allows it to build up and hit this threshold at about minus 55. And that minus 55, that's called, well, this is known as the threshold level. And at this point, you get these voltage gated sodium channels that open. So you have these voltage gated sodium channels, and they cause a great influx of sodium. So loads of, you know, positive charges entering the cell, and so it becomes depolarized. So you get depolarization as a result of this. Now, when it hits about plus 30 millivolts, what happens is these voltage gated sodium channels abruptly close. It's a very short amount of time that they're open for, but they cause a great influx. And then when they've closed, these voltage gated potassium channels open. And remember, a lot of the time potassium, because it's intracellular, it tends to leave the cell from inside out. So they cause a great efflux of potassium, and this great efflux causes more positivity to leave the cell. So you get this repolarization. And what happens is these voltage gated potassium channels, they're a bit delayed at closing. So you get this overshoot between when, the potassium channels are delayed in closing. So you get this overshoot between about minus 90, and it actually overshoots to about, at minus 70, and it overshoots at about minus 90 millivolts. And that's when they close. And this overshoot's known as hyperpolarization. Now, it comes back up again due to this sodium potassium pump. It brings it back up to that resting potential. And obviously that's one action potential done, and the whole sequence it carries on, the next action potential starts it, and so on. So the sodium potassium pump brings it back up to that minus 70. Now this period between which you can see that this hyperpolarization up until when it reaches that resting potential again, this is known as the effective refractory period, the ERP. At this point, no new action potentials can be generated. So no new action potentials can be generated here at this point. So that's just an important note to take. Now, say this electrical impulse reaches the end of an axon where the signal has to be turned into an electrical signal, has to be turned into a chemical signal, and then, drift over and then become an electrical signal again. So that's at the end of an axon. We need to look what happens there in order to see where calcium's involvement is. So we need to be looking at a chemical junction and a chemical synapse. So I'm going to draw a pre-synapse here for you, and then say this is a post-synapse. Okay. Now on the pre-synapse, you have this voltage gated calcium channel, and then you have these vesicles. These vesicles contain neurotransmitters, and as we're talking about, a muscle in this case, that normally involves the neurotransmitter acetylcholine. So we put this one as an example here. Now, say an action potential is being, carried on, and you've hit the end of the axon, for example. What happens is, normally this voltage gated channel is closed, and then when the action potential comes along, it actually causes it to open. So what happens when this, voltage gated calcium channel becomes open? Well, obviously it allows this big influx of calcium, and this influx of calcium, what it does is it allows these vesicles that contain a neurotransmitter, so say acetylcholine in this case, to fuse to the membrane and release their contents. So it causes it to diffuse into the synapse and diffuse across to these postsynaptic receptors. and it activates them. So in this case, we're talking about nicotinic and muscarinic acetylcholine receptors. So when these are activated, normally in the muscle, that causes contraction of the muscle. So it causes contraction of the muscle. So the muscle contracts, and obviously afterwards, the acetylcholine may be taken up by acetylcholinesterase in the pre-synapse, where and it's degraded. And anyway, so it causes contraction, and that's important because obviously if we have no calcium coming in, so say for instance, taking this back to the cyclic GMP, that increase in cyclic GMP, remember, that may basically inhibit calcium entry into the cell. That's going to inhibit release of these vesicles. And then the acetylcholine, obviously you haven't got any to bind to these nicotinic and muscarinic acetylcholine receptors, so you're not going to get contraction. Instead, what you're going to get is you're going to get this relaxation of muscle. And what does this mean? Well, remember, say for instance, here's your vascular smooth muscle. Normally, the blood vessel's constricted when there's contraction, and so the diameter is quite narrow. So, there's high pressure, so there's high blood pressure because obviously your peripheral vascular resistance is high. Now, when there's relaxation of this muscle, it means that the blood vessel becomes dilated. If it's dilated, diameter is wider, obviously the pressure is not as high, so obviously the blood pressure drops. So you got to reduce blood pressure as you got to reduce peripheral vascular resistance. So that's the first way in which you get this rapid vasodilatory effect. Now, the second way that cyclic GMP causes this is it stimulates a cyclic GMP dependent protein kinase that activates myosin light chain phosphatase. And this phosphatase is an enzyme that dephosphorylates myosin light chains, which leads to a relaxation of smooth muscle. So it increases this cyclic GMP dependent protein kinase, activates myosin light chain phosphatase. Now, in case you're not sure, about myosin and actin, myosin and actin are basically, they're the two main types of proteins. They're also known as thin and thick filaments that slide over each other as part of the sliding filament theory that intertwine in this theory to help explain muscle contraction and relaxation. So I can give you a little bit of background into this by going on to the next slide. So this is going to be a little bit of physiology. Specifically, we're going into myology, so study of muscles. So you have these, so say this is, actin, sort of like a helix. So say this is your actin, And then you've got this tropomyosin, sort of acts to cover this binding site found on actin, known as the actin. You can sort of think of it like an active site. An actin binding site on actin, and that's covered by tropomyosin. And then you've got this troponin which is there. And then you have, so that's actin, and then you have your myosin, the myosin is the thick filament. So these myosins are normally helixed in pairs. So this is the myosin head. They normally have this ATP binding site. They all normally have this actin binding site. So normally, if we zoom out and we look at a sarcomere, which are these repeating units that help make up the muscle, you've got, this is a zoomed out picture quickly. So I'm just going to do a quick zoom in at one. So normally you have these, single sarcomeres. I've drawn one unit here, and you often have, say, this as the myosin, and you've got this as the actin, and this normally slides, say this is the myosin head, and it normally slides over this, and when they slide over each other, and the head does this power stroke across and detaches, these two, so you have this set of actin parts of, from one Z disc to another, they basically get closer together. So you have Z disc and M line, and then when they get closer together, and so obviously the length of the sarcomere, it gets shorter. So because the length gets shorter, that's your contraction. What I'd say is, if you think about the muscle, say this is your arm, a bicep, when it's relaxed, obviously the muscle's longer, and when you contract the bicep, obviously the length is shorter. Because it's a shorter length, that's obviously your contraction. Now obviously, say we're zooming in on this myosin actin reaction process that's occurring here. So we've got, this is your actin, this is your myosin. You've got the actin binding site, which is covered by this tropomyosin, which goes over it, and then you've got this troponin that's attached to that tropomyosin, and then on the myosin you've got the myosin head, and it says ATP binding site, and you've got an actin binding site, which is complementary to that actin, sort of, you can think of it like an active site. Now, if I move this tropomyosin out of the way, so you can see. Now what happens is, you normally have ADP and a phosphate here. Now, say calcium comes along from wherever, that normally binds to troponin, and that basically pulls this tropomyosin and allows it basically causes it to twist away from the actin binding site, so where that quote, active site of actin is, if you think about it, and it allows it to become exposed. So it's now exposed. And because it's exposed, and now the myosin head, it can basically bind to its actin binding site. So, but it's not ready yet, because obviously this phosphate has to detach away. Then it binds on, and then it's when it so we zoom in here. So attached on there, and now it sort of pivots across, and they call this like a power stroke motion. And then when it's detaching off, it sort of utilizes this ATP using ATP hydrolysis. It utilizes ATP, and obviously this allows it to sort of pivot away back. Otherwise it's stuck in that contraction mode. So then it can pivot back to how it was. And then that ATP loser phosphate goes back to ADP and phosphate. Now, the thing is, obviously this is where you get that muscle contraction and muscle relaxation, you can see. Now, we have an issue that you'll be able to see already. Now, say cyclic GMP, it reduces, it has that, stimulates a cyclic GMP dependent protein kinase that activates this myosin light chain phosphatase, which acts on this myosin, and that basically dephosphorylates myosin light chain, which obviously is going to lead to this. Because it's an enzyme that dephosphorylates those myosin light chains, obviously you're going to get rid of that, phosphate, and so it's going to stay in that relaxed state. So it's going to stay in that relaxed state, and because it's staying in that relaxed state, obviously your vascular smooth muscle, if we go back to it, this vascular smooth muscle in the relaxed state, the diameter is obviously wider, your pressure is not as high because the blood vessel's wider, and that's how you get that reduced pressure there. Now the last effect it has is it has this effect on potassium channels, and it causes them to open up. Now remember, potassium leaves the cell because it's an intracellular ion that goes from in to out. That causes hyperpolarization. Now remember our action potential graph. If potassium leaves the cell, you're going to get this repolarization and get this hyperpolarization where it overshoots. And obviously if you're getting rid of that action potential, you're not going to get to this phase of this, calcium coming in, and you're not going to have any of this, you're not going to have any of this contraction. You're going to have muscle relaxation. So because this muscle's relaxing, then obviously you're going to have a reduced peripheral vascular resistance and a reduced pressure. So the third one is potassium channels opening. So you can see all three effects there. Now, although both arteries and veins become, dilated, they're both involved in that vasodilation effect by those muscles. They relax. It's usually veins that are affected more than arteries, predominantly. So because the venous dilation predominates when you give it at therapeutic doses, this is going to cause a reduction in venous pressure and a reduction in what we call ventricular preload, because you're dilating the vessel so much. Now, what's ventricular? What is preload? So preload is that initial stretching of the myocyte. So this initial stretching of the myocyte, so say we've got a cross section of a heart here, we sliced it when we're looking directly on at the heart. This preload, say blood comes into the, fill in these chambers, fill in the left and right ventricle. This initial stretching, just before the blood gets ejected out, like an elastic band, just before it gets pumped out through the semilunar valves. Imagine it's like an elastic band. So you pull the elastic band, the harder you pull it, then, when you let go, more blood's going to get ejected out. So obviously, if there's more blood flow, if there's more pressure, it's going to be forced to stretch more. Now, what that's going to happen is, say we take a look at the myocytes, we zoom in on them. Obviously, that's going to take more oxygen. When the myocytes are forced to stretch to a greater extent, then obviously that takes more oxygen. So it's going to take more oxygen. So it means it's more likely some of these cells might not be able to cope and they'll actually, die. So you get necrotic tissue. And then sometimes even potentially some of the other cells, they have to make up for the slack. So sometimes they even remodel, and that cardiac remodeling can be a complication, and that can actually lead to, heart failure and stuff. But that's, not common. But even just the necrotic tissue dying because of lack of oxygen, because so much oxygen is needed, it will cause the myocardial oxygen demand, so the oxygen demand, to be greater than the oxygen supply. So the oxygen that's supplied, it's not enough. And obviously that's going to exacerbate certain conditions that require improved, oxygen flow, like angina. And it can even potentially lead to a myocardial infarction where there's insufficient blood flow to the heart. Now, obviously, if you decrease the preload, because you're decreasing the stretching, so it's not stretching as much, then obviously, you don't require all this, oxygen. If you don't require this oxygen with the myocytes, they're not forced to have to, stretch as much. And so what happens is the oxygen demand, it's not that great. It's the amount, because the oxygen supply is now greater than the oxygen demand. So, you're not going to get this angina, attack in patients, and you're not going to get complications. Because obviously you've got less wall stress when they're filling the chamber. Now, obviously, this is going to help a lot in conditions like you see with Mr. Angina. Number two, any systemic, arterial vasodilation, this is going to help where, by reducing what's called afterload. So this reduces afterload. You're probably wondering what is afterload. Now, afterloads are the load in, say you're ejecting blood out. It's the load against which the heart has to push against in order to get blood out. So imagine the pressure's high. So then that means that the heart has to, and the myocytes are, being stretched and let go. The amount of blood they have to push against, that's your afterload. And obviously, if there's higher pressure, the afterload's going to be higher. Now, if you're able to cause vasodilation, you reduce that pressure, and you're going to reduce afterload because it's got less to push against. So it's actually got, you've only got less to push against now. And that's really good, because that means you've got, you know, again, the oxygen demand, because the heart would actually have to, because it needs to push harder, it needs more from these myocytes. So that means your oxygen demand actually decreases and the oxygen supply is sufficient. So that means it's going to be good for conditions like angina. Now, you might think, okay, all's well. Now you have to be careful, because of all this vasodilation that's going on and all this reduction in blood pressure. If it gets too low, it can actually trigger these receptors found in the aortic arch of the heart, and these are called baroreceptors. So those are these little baroreceptors, and they actually detect that tension and pressure in the arteries. And if they get too low, they can activate what's known as the Baroreceptor Reflex, and it's sort of like a homeostatic response in order to increase the blood pressure back up. So it sort of activates certain sympathetic nervous system responses, including an increase in heart rate. Remember, blood pressure is equal to cardiac output times peripheral vascular resistance. And cardiac output, which is the total amount of blood pumped out of the heart per minute, is made up of stroke volume, and peripheral vascular resistance. Peripheral vascular resistance is made up of stroke volume and heart rate. Remember, stroke volume is the total amount of blood pumped out of the heart per beat, and the heart rate's beats per minute. So obviously, if you increase heart rate, you're going to increase cardiac output, and you're going to increase blood pressure. And so obviously that's to get the pressure back up. Now, this is why in patients that you give, you know, nitrates to, they might get reflex tachycardia as a result. And, you know, a lot of vasodilators, this can be a reflex effect that you can get, and why it might be, you know, experienced as a side effect. So that's one thing to bear in mind. Now we move on to Pde5 inhibitors, so Phosphodiesterase 5 inhibitors. So where do these come into effect, and what's the mechanism of action of these drugs? Now, say we have this, we have we have nitric oxide, and that acts on, to increase the activation of guanylyl cyclase, to turn GTP into cyclic GMP, and so on. Now, cyclic GMP is actually degraded by an enzyme known as phosphodiesterase 5, and obviously you can see that phosphodiesterase 5 inhibitors are going to prevent degradation of cyclic GMP, and what that means is they can have all those three effects. So that means you're going to get this vasodilation effect, because you're going to have constant relaxation of the muscle, and so the vessel diameter is going to stay wider, and so the pressure is going to be lower. And what that does is it allows increased flow to the corpus cavernosa, which is just another name for penile tissue, and that increased blood flow allows male patients to maintain an erection, but as long as sexual stimulation is present. If sexual stimulation isn't present, that's why I hear some patients like, it doesn't work. It's because that sexual stimulation or activity needs to be going on. So that's why it's usually taken, for example, let's take sildenafil. It's usually given 1 hour prior to when a sexual event is going to take place, and that allows for maintenance of the erection. Now you can see how it works there. Now you can probably see where the problem's going to come into place, and how there's a pharmacodynamic interaction between nitrates and Pde5 inhibitors. So if a patient's taking both a nitrate, this is going to cause an increase in obviously nitric oxides, and obviously that's going to cause an increase in cyclic GMP, which is going to cause this vasodilation effect. And now on top of that, if you're giving someone a Pde5 inhibitor, you're stopping degradation of cyclic GMP, so it's going to increase even further, and you're going to get an even greater vasodilatory effect. And that is exactly why you can get this abnormal prolonged vasodilation, which results in excessive hypotension, reduced blood pressure, and even potential circulatory collapse if the flow's reduced great enough. And this interaction's true even if a patient's taking a pro-Renada, so a PRN nitrate, so when required nitrates such as GTN spray. And this drug therapy problem should definitely be flagged up with the prescriber. And there's a few things we can, options if the prescriber asks about, taking these two drugs and how to sort out the issue of hypotension. So due to the half-life of the drug, so let's take sildenafil, because different phosphodiesterase inhibitors, they vary in their half-life. So let's take sildenafil. So the elimination half-life is about 24 hours. One thing, so there's a couple of common things that they might try. So you can advise the patient during sexual intercourse, not to actually take or use their GTN spray, because obviously then it's going to get into their bloodstream and they may cause an excessive reduction in blood pressure. Whereas if they don't take it, just stop sexual activity to, because that exertion may be causing greater oxygen demand, and just to wait 5 to 10 minutes. And if, there's no relief, then to call 999. Obviously, there's still some small risk by doing that, but it is a potential option. But personally, I don't usually try to go for that one. That's number one. Number two, and this is probably more practical, is to actually try a localized topical Pde5 inhibitor. An example of this is alprostadil cream, and this is applied locally to the penis to obviously cause the same increased flow and maintenance of an erection. Or sometimes you might see some patients actually given this VED, which is a vacuum erectile device, which is a non-pharmacological option that can be discussed, and that vacuum basically helps to give the patient an erection, and it requires mechanical stimulation. Now, with the first drug therapy problem identified, let us move on to the next issue. So if you take a look, the next issue is to do with our rate limiting calcium channel blocker. Now, these are used to prevent future angina attacks, as I said previously, but the actual formulation that's been given here, modified release, and it's actually more than 60 milligrams. Any, diltiazem modified release prep that's more than 60 milligram should be given as a brand. It should not be prescribed by generic, because brands can vary in clinical effect due to the way they're absorbed. and they should also distinguish between a once or twice daily preparation, and this can make the difference whether a patient has future angina attacks or not, due to the amount that's in their blood and so on. So that's something to bring up with the prescriber. I know sometimes some people might say, oh well, they're a regular patient at this pharmacy, they know what brand they're on, but what if a patient can't get to that pharmacy, so they have to go to a different pharmacy and they give a different brand because it doesn't specify what brand is meant to be given, then and the surgery is not open to call to clarify, then there may be, and the patient's not sure, then there may be some confusion. Then there's just no point having all that hassle and taking all that risk, so this is the safest option. So with the second drug therapy problem identified, let's move on to the patient query portion of the case study. Mr. Angina comes very anxiously into the pharmacy, informing you that he can see round objects in his stools. Mr. Angina says at first he thought it might have been something to do with this new green tea his wife bought him, saying it's good for his heart. But even stopping this hasn't done anything. He goes on to ask if it's anything to do with having angina itself, since it all began after he was discharged from hospital and put on his regular angina medication. Now, Mr. Angina is most likely referring to what is known as a ghost membrane. Now, certain brands of certain drugs, in this case diltiazem, the specific brand being tildium retard or tildium retard, once having its contents released and absorbed, leaves behind its membrane, and this membrane basically passes through the GI tract unchanged, and it just gets excreted as part of the fecal matter. And so the casing, that's probably what Mr. Angina can see in the fecal matter, and this is probably what he's referring to. And this ghost membrane is completely harmless, so just inform Mr. Angina of what he's seeing in his stools and reassure him it's just completely harmless. If he's still really anxious, then potentially refer him back to his clinician. Now that completes today's clinical question time case study. I hope you found it useful. If you could please subscribe, like and share, and remember to hit the bell symbol when you subscribe to make sure you get notified of future videos. I hope you found it useful, and I'll see you next time.